Clinical epidemiology applies epidemiologic principles to patient care and research. You'll learn to measure disease frequency, identify risk factors, and evaluate study designs and evidence to guide clinical decisions. These skills support evidence-based dental practice. For questions, contact Professor Ananda P. Dasanayak, NYU College of Dentistry, at anandanyu@gmail.com. This session introduces the basic principles of epidemiology and how we measure disease occurrence. You'll learn core functions of epidemiology, methods for quantifying how common diseases are in populations, and how to interpret prevalence and incidence trends for major oral diseases over time. You can complete CPH lessons 1 through 5 to reinforce these ideas. Recommended readings include recent reviews on COVID epidemiology and a 10-year study on tooth loss for further context. Epidemiology combines people and science to understand what happens to populations. It asks who gets sick, why, and how often. Using data, surveys, and pattern analysis, epidemiologists identify causes, track outbreaks, and guide prevention efforts to protect public health. Different populations face major oral diseases such as dental caries, periodontal disease, oral cancer, congenital anomalies, orthodontic problems, and trauma. To gauge burden, we measure incidence, prevalence, and severity with standardized tools: caries indices, periodontal staging, cancer registries, congenital anomaly records, orthodontic indices, and trauma reporting. Combining clinical exams, radiographs, and population surveys lets us quantify need, guide prevention, and allocate resources effectively. Epidemiology looks at how health events are distributed in groups and what determines their occurrence and associations. It studies who gets sick, when and where, and why patterns exist. By measuring these distributions and identifying determinants, epidemiologists inform strategies to prevent and control health problems at the population level. In short, it combines observation and analysis to guide public health actions and reduce disease burden. Common oral conditions arise from immediate causes, bacteria, sugar, and behaviors, and from distant social factors like poverty, lower education, and limited access to care. Trauma and congenital anomalies also contribute to malocclusion and other problems. Recognizing both immediate and upstream causes guides prevention, clinical care, and policy to reduce disease and oral health disparities. Healthcare in the United States costs an enormous amount, about $4 trillion each year, roughly 18% of the economy. That averages to over $12,000 per person annually. Much of the spending goes to hospital care, prescription drugs, and administrative overhead. Understanding these figures helps explain why controlling costs and improving access are major goals in health policy today. Dental care accounted for 4% of national health spending in 2022, about $180 billion out of roughly $4.5 trillion. Compared with hospital and physician services, dental is a smaller share, yet it still represents a substantial investment. Tracking this helps explain choices about coverage, prevention, and resource priorities in health policy. Total U.S. health spending rises steadily from about $3.3 trillion in 2016 to roughly $5.3 trillion in 2025. Major components all increase. Hospital and personal care, professional services, and prescription drug spending grow significantly, while retail medical sales expand. Nursing homes and home health also rise, reflecting greater demand. These changes largely reflect higher use, higher prices, and an aging population. Dental services cost $194 billion in 2025, an increase from $126 billion in 2016. Routine dental care varies widely. Cleanings and simple extractions often cost under $100. Fillings and root canals range from a few hundred to about $1,000, while veneers, crowns, bridges, and implants can cost $1,000 to $5,000. The Consumer Price Index tracks these price changes over time. In 2024, dental services were about 4,365% higher than in 1935, showing long-term inflation. About 8.5 billion people live on Earth, and nearly half, 45%, have oral disease. That adds up to around 3.8 billion individuals affected worldwide. Treating and managing these conditions costs a combined public and private total of approximately $387 billion. This shows oral disease is both a major health problem and an economic burden that requires stronger prevention and care. Dental caries begin as tooth decay caused by bacteria and sugar. If untreated, decay can reach the pulp and form painful abscesses. These infections can spread to nearby tissues and rarely into the bloodstream or brain, becoming life-threatening. The image and news report highlight that routine dental care and timely treatment prevent severe complications, so seek a dentist promptly for persistent pain or swelling. This particular case led to bill in the United States House. This 14,000-year-old lower right third molar from a Paleolithic man still shows tooth decay, proving dental caries affected humans long before agriculture. Cavities like this reveal how ancient diets and oral bacteria interacted. Studying such teeth helps researchers track when cariogenic foods and behaviors emerged and how patterns of dental disease changed across human history. Caries burden varies across populations. Key factors include age, gender, race and ethnicity, socioeconomic status, poverty, income, education, and geographic location. To measure how many are affected, we use morbidity metrics, prevalence for existing cases, incidence for new cases, and magnitude to capture overall severity. Understanding these dimensions helps target prevention and allocate resources. Prevalence measures how common a disease is at a single point in time. It is the number of existing cases in the population at that specified time divided by the number of people at risk in that same population in time, and then multiplied by 100 to express the result as a percentage. Think of prevalence as a snapshot that shows current disease burden and helps guide public health planning. If we want to measure caries prevalence among NYU first-year dental students in January 2025, prevalence is the number of students with at least one cavity, filling, or a tooth lost to caries, divided by the total number in the class, 404, and multiplied by 100 to express a percentage. Caries data can be collected by asking students, performing clinical exams, or taking dental x-rays. Calculate prevalence of untreated caries by taking the number of NYU D1 students with at least one untreated cavity, dividing that by the total examined 404, and multiplying by 100 to get a percent. Identify cases by asking about dental history, performing a clinical exam, and taking radiographs when indicated. This produces the January 2025 prevalence of untreated caries among first-year students. Untreated dental cavities have fallen sharply among children aged 5 to 19 since the late 1980s, from about 24% to around 13% by 2015 to 2018 in young individuals. Improvements are smaller for adults aged 20 to 44. Persistent gaps remain. Rates are higher among Black and Hispanic groups and among people below the poverty line, showing dental disease is linked to social and economic factors and needs targeted access to care. About half of Hispanic children had dental caries in 2015 to 2016, higher than other groups. Non-Hispanic Black and Asian youth also showed elevated total caries compared with white youth. For untreated decay, non-Hispanic Black children had the largest share, suggesting gaps in access to dental care. These patterns highlight the need for targeted prevention and improved community oral health services. Untreated dental disease is common. Before the pandemic, about 46% of children ages 2 to 19 had untreated or restored cavities, and 13% of adults 65 and older had complete tooth loss. Around 1/4 of adults had untreated cavities. About 66% of adults had a dental cleaning in the past year, and nearly 87% of children had a dental visit. Incidence rate measures how often new cases occur over a defined time. The numerator counts only new cases during that time. The denominator is the total number of people who were at risk and followed for the entire period. Always specify the time period and any scaling, for example, per 100,000 people, so comparisons are meaningful. Incidence of caries here means how many new cases of dental caries appear over the D1 cohort's 4 years. We calculate it by taking the number of students with new caries in 2029 and dividing that by the number who were caries-free in 2025, multiplied by 4 years of follow-up. Note that some students won't complete follow-up, which affects the final estimate. Our detection of caries achieves high precision in typical conditions, but it is not perfect. Accuracy depends on methods used, data quality, age of cases, and the operating environment. Expect occasional false positives and false negatives. We provide confidence intervals and recommend human review for critical decisions. Models are retrained with new data to reduce errors and improve performance over time. Deep, narrow occlusal fissures can hide decay because explorers and toothbrush bristles cannot reach the base. The cross-section shows an inaccessible area where plaque accumulates, while the tooth photo and panoramic radiograph illustrate how caries may progress before detection. Preventive measures like fissure sealants or careful monitoring with radiographs reduce hidden decay and preserve tooth structure. Dark staining or a sticky probe in an occlusal fissure often indicates caries that has reached dentin. The left photo shows surface staining and fissure breakdown. The cross-section on the right reveals decay within enamel. When caries reaches dentin, the lesion progresses faster and usually requires removal and restoration to stop spread and restore tooth function. Dark staining in a fissure doesn't always mean decay, but here the fissure stain and the cross-section show breakdown extending into dentin. Note the brown lesion beneath the enamel surface that indicates caries penetration. Clinically, inspect fissures closely. Use gentle probing and adjunctive radiographs or transillumination. If dentin involvement is confirmed, remove infected dentin and restore the tooth to prevent progression toward the pulp. Common diagnostic methods, the Tactile Explorer and 2 visual exams, have modest sensitivity and higher specificity. Explorer, sensitivity 60.5%, specificity 87.4%. Visual, University sensitivity 65.0%, specificity 82.5%. Visual, private practice, sensitivity 61.8%, specificity 83.3%. So these methods miss about 3 to 4 out of 10 caries, but produce relatively few false positives per Lucy 1991. Diagnostic methods vary. Sensitivity measures how well a test finds actual caries, specificity how well it identifies healthy teeth. Clinical exam has low sensitivity, about 38%, but very high specificity, 99%, so it misses many lesions but rarely gives false positives. Fiber optic transillumination detects more disease, about 67% sensitivity with 97% specificity. Radiographs sit in between, and combining methods improves overall detection. When evaluating fissures, think in 4 outcomes: sound tooth, early occlusal caries limited to enamel, suspicious dentinal caries where decay may reach dentin, or frank cavitation requiring restoration. Clinical detection has low sensitivity, so combine visual exam with careful probing, radiographs when appropriate, and patient risk assessment. Use conservative treatment when possible and monitor early lesions closely. Diagnostic mistakes are common. About 35 to 40% of true lesions are missed, causing delayed care. Healthy teeth are sometimes unnecessarily treated, occurring in 13 to 18% of cases and causing unnecessary harm to sound structures. Approximately 27% of treatment plans are inappropriate, reflecting interpretation or judgment errors. Recognizing these patterns helps prioritize better imaging, careful review, and second opinions to improve patient outcomes. Translate these concepts into practical steps. Prevent risk factors through education and behavior change. Implement routine screening for early lesions. Train clinicians for timely diagnosis and ensure access to appropriate treatment and follow-up. Monitor outcomes with simple surveillance and adapt interventions based on results. These combined actions help control the oral health problem and protect the wider community. Primary prevention aims to stop disease before it starts by lowering people's exposure to risk factors or by boosting their resistance. These actions often target whole communities rather than individuals. For example, adding fluoride to public water supplies helps strengthen tooth enamel and reduces cavities across the population. This is a political debate now. Secondary prevention focuses on finding and treating disease before symptoms appear to stop progression. In dentistry, this means detecting early enamel changes through exams and risk assessment, then using non-invasive measures. For example, fluoride varnish applied to early enamel lesions can promote remineralization and prevent cavitation. It's a simple, repeatable adjunct to good oral hygiene and routine professional care. Tertiary prevention focuses on reducing harm once disease is established. Its aim is to preserve function, extend life, and improve quality of life through rehabilitation, restorative treatments, and ongoing chronic care. In dentistry, this idea is often called drill, fill, and bill, which simply means repairing damage and restoring function so patients can eat, speak, and carry out daily activities more comfortably. In summary, oral diseases are common worldwide, affecting about 45% of people and costing healthcare systems heavily. In the United States, dental care accounts for over $190 billion. Many avoid care. A third of Americans had no dental visit last year. Untreated decay and gum disease are widespread, and oral cancer causes roughly 60,000 diagnoses and 12,000 deaths annually. Prevention can substantially reduce these burdens. Thank you.